And now we're going to continue with more presentations this afternoon, or here this late morning, I guess. Gretchen MacCarrick is going to be our next presenter. She is the genetic counselor at Johns Hopkins University. She's a genetic counselor in the Department of Genetic Medicine at Johns Hopkins, specializing in, genetic conditions, and has been doing so for over 19 years. In addition to clinical care and research, she serves as a supervisor of genetic counseling students and residents, providing direct supervision and didactic education about various genetic counseling issues within this population. She has extensive experience and with parent and adolescent support. She's an advocate through her involvement with the Marfan Foundation and their annual conference. She is the co-founder and board member of the Loeys-Dietz Syndrome Foundation, and she's on the professional advisory board of the Marfan Foundation. So Gretchen MacCarrick is here with us today. So thrilled, from Johns Hopkins University. Let's hear her presentation now.
Thank you to Amy and the other organizers of Rock from the Heart. I'm really happy to be here talking to you today about genetics and thoracic aortic disease. So just as a reminder about vocabulary, when we're thinking about aortic disease, we're talking about both aneurysms and dissections. So an aneurysm is really a bulging or widening or dilation of the aorta. It can be in the aortic root, which is the most proximal part of the candy cane tube of the aorta as it leaves the heart. The ascending is just a little bit distal to the root. And then we have aneurysms that can also develop in the arch, as well as the descending, the portion as it's coming down into the belly, as well as abdominal aortic aneurysms. So a dissection is really a tear then in the lining of the aorta, and it's referred to as a type A dissection if it begins in the root or ascending, really that thoracic aorta. And that type A dissection can just be limited to that area, or it can actually unzipper the aortic tissue down into the descending or all the way down into the iliac arteries as they go into the leg. And then a type B dissection is a dissection that begins in that downward section of the aorta, in the descending aorta. So when we think about thoracic aortic disease, we kind of seen two flavors. One is sporadic disease, and these risk factors typically go along with an older age of presentation, a bit more common in the male sex, and go along with a lot of environmental features, such as someone having a long-standing history of coronary artery disease, high blood pressure, smoking, perhaps heavy weightlifting. There can be a variety of illnesses and medication exposures that can also increase risk for aneurysm and dissection. And today's talk is really going to focus on the familial type of thoracic aortic disease. So we know about 20% of individuals with aortic aneurysms have a family history. In these families, we see aneurysms and dissections occurring at younger ages. There can be both syndromic and non-syndromic presentations, meaning that there can be external skeletal or cutaneous clues to the diagnosis. And in these cases, there tends to be a stronger genetic influence. So when someone presents with an aneurysm or dissection, what are some of the evaluation tools that we use to make a diagnosis? One of them is the imaging review, so either echocardiograms and often CTAs or MRAs to look at all of the vasculature. In these studies, we're really looking for aneurysms and kind of where the aneurysm is. Is it in the root? Is it in the ascending? On the echo, we're also looking for congenital heart defects, so not only holes in the heart, but is there valve floppiness like mitral valve prolapse? Is the aortic valve that is typically tricuspid or three leaflets? Is it bicuspid, which we know is a risk factor for aneurysm and dissection? And then on MRA or CTA, we're looking for things like other arterial aneurysms or dissections. So sometimes small dissections can happen in the carotids or vertebrals, the arteries in the neck, sometimes in the iliacs or in the branch vessels going off from the abdominal aorta. And then we also can sometimes see arterial tortuosity or these winding or curvy blood vessels, which aren't bad blood vessels, they're just diagnostic clues to some genetic conditions. So in addition to imaging, we're going to go through a good physical exam, or at least review of systems of head to toe, to look for any other constellation of features that might be indicative of a syndromic presentation. So when thinking kind of head to toe, we think about craniosynostosis or premature fusion of any skull bones. There can be cleft palate or high palate. In the ocular system, some clues include eye muscle diseases or wandering eyes when people are young kids. There can be myopia or retinal detachment, lens issues, and some other eye conditions that are indicative of smooth muscle conditions. Additionally, moving down in the chest and the back area, we think of pectus deformities, or where someone's chest wall might poke in or poke out, collapsed lungs, hernias, scoliosis or kyphosis, different curvatures of the spine. You know, in the extremities, there can be long fingers or toes, or they can be contractures or kind of flexion of those hands and or fingers and toes. When thinking about joints, we can see some hyperflexibility, maybe dislocations or subluxations, and the skin can also help us. Some individuals have significant striae, abnormal scarring or wound healing. They might have translucent skin or really easy bruising or bleeding. We also take into account the family history. So this is a picture of a pedigree, which is a tool that geneticists and other physicians use to kind of quickly track, you know, features in a family. And so this is a way that we can look at other medical conditions, other sudden cardiac deaths, any of those syndromic features of connective tissue disorders, and track them in the family and see if there's any other people that we think are at risk, or if there's any patterns we see in the family of health conditions running in the family. All of this leads to the genetic testing process. So genetic testing is really a way where we're looking for DNA changes within a subset of genes or instruction manuals that could predispose people to specific medical conditions. And in aortopathy disease, this can be helpful because it can confirm a suspected diagnosis to help give us important information. It can also rule out disorders that may alter management. So kind of generalized guidelines say maybe we do aortic root surgery at around 5 or 5.5 centimeters, but in some of these disorders, those surgical thresholds would be lowered. And so it's also important to rule out the very aggressive conditions that would certainly change management. Finding a DNA variant on this genetic testing can allow us to offer testing to other family members to determine who is at risk and needs screening versus who is at not. It can also help with family planning. So there are technologies through IVF or prenatal testing when a woman is already pregnant to determine if the embryo or the fetus would have the condition, to help mentally or emotionally prepare the family or help make arrangements for care after birth. It can also help us to predict what might happen to the patient. So of course, we don't have a crystal ball to know with 100% certainty what is going to happen, but there can be some generalized rules to help better predict the future for that patient. And then clinical management is really based on the gene altered. So it helps us determine risk for non-vascular disease, such as allergy or GI disease or orthopedic concerns. Again, the timing of aortic aneurysm repair, what thresholds do we use for intervention? What types of dissections may occur, and risk for other vascular disease. Is there a risk for aneurysm or dissection in the head or neck vessels? Is there a risk for early coronary artery disease or strokes? And finally, genetic testing can sometimes help us with enrollment in research and clinical trials to move our knowledge forward. So genetic testing is a little unique. It's more than just a blood test that you get back looking at a number, like some of your routine CBCs or CMPs. A result can really have multiple implications. There can be psychological implications. So, you know, aneurysms don't really present with a lot of physical manifestations in terms of cardiac pain or palpitations. And so seemingly healthy people can all of a sudden get this risk for sudden death, which can have a large mental or emotional toll on someone. There can be reproductive implications, thinking about would you want to have a child that has the same predisposition to aneurysm or dissection? And again, this result just doesn't impact your care, but it has familial implications. And finally, there can be insurance implications. So right now there's non-discrimination acts, so someone can't be discriminated against based for health insurance for a pre-existing condition, but that's not the same for long-term care insurance, life insurance, or perhaps disability insurance. So there are quite a few different genetic testing strategies that, based on your presentation, based on your family history, would be considered by your geneticist. You know, mainly in aortopathies, we're considering aortopathy panels. These are offered by multiple labs, usually between probably now about 30 to 50 genes, and they are pretty routine at different labs. So it actually is pretty easy to get these days. So just some context about genes and thoracic aortic disease. We have about 23,000 pairs of genes. We only know what about a third of them do, or how they're associated with human disease. So as 2021, we just don't have incredible knowledge to know what 2/3 of our genetic information does and how it impacts human disease. And so then when we're thinking really about aneurysm panels and we're down to about this 30 to 50 gene panel, you can clearly tell that we have a lot to learn about genetic impact on aneurysm disease. And in fact, studies do show that in adults who have milder disease, we are only able to find a genetic answer in about 20 to 30% of patients. And again, this number is more likely to be on the higher side of detection when we have a younger age of onset, when we have syndromic features, and if there is a family history of disease rather than just one person presenting sporadically in their family. So who should get tested? Clearly, if you have any musculoskeletal or cutaneous features of a syndrome, we typically tend to think of people who have a history of aortic dissection or larger aneurysm, less than 60 years of age, or if there's a family history of sudden cardiac death, aneurysm, or dissection. We typically like to test an affected person first in the family and then able to test other people who might have normal aortas in the family. Before getting tested, we certainly recommend sitting down with a genetic counselor or a genetics professional to go over the testing and the limitations. We do suggest that if possible, especially if you're testing children or young adults, if an adult has had an aneurysm or dissection, you know, to have those uncomfortable conversations, thinking about life and disability insurance getting in place first. And then talking with a genetic counselor can help kind of ease your mind about, is insurance going to cover this testing? How much does it cost? The testing itself can be done via a buccal swab or a saliva sample, all via mail. You know, we test for all genes at the same time, and results take about 4 to 6 weeks. In general, anytime we do a genetic test, there can be 3 answers. It can be clearly positive. So we've identified a pathogenic or likely pathogenic gene change. We feel like this is the answer. We can use it to take care of you and your family members. It could be negative. So that means no genetic change is identified. It doesn't mean that what you have is not genetic. It just means as of 2021, we're not smart enough to find it. And then we can get something called a variant of uncertain significance. So this is a gene change where we're not 100% sure. We can blow it off as a rare, you know, Italian variant, but we're not 100% sure this is the answer for the family. So as geneticists, we look at population data and see how frequently is it described. Has it been described in the general population? Has it been described in someone with aortic disease? Oftentimes we need to track in the family. So if multiple people have aneurysms, does that gene change track in all of those people with disease? And is it absent in people without disease? And then, you know, we have a great cohort of aortopathy centers of excellence all across the United States. So we certainly ask each other for advice. So the aortopathy gene panel, I have to say, some of the genes on this panel have to go along with intellectual disability or kind of a Marfanoid habitus, but not really aneurysm or dissection risk. And so it can get very confusing to get variants of uncertain significance on these other genes. All of this to say it really is helpful to make sure that you're getting the test by a geneticist or a genetic counselor who has really explained the outcomes and can help you through any variants of uncertain significance. So before we talk on some of the syndromes, just a word on inheritance. So most of these conditions that we're talking about, or aortic disease in general, are inherited in an autosomal dominant fashion. So what this means, or what implications it has, is that if we are unable to find a genetic answer for your family, we do recommend then that all first-degree relatives, so parents, siblings, children, undergo an echocardiogram for screening if we're not able to offer them a blood or saliva test to find that genetic answer for predisposition. And this is also something that a genetic counselor can help you with. If your testing is negative, they can often help you come up with a family screening letter that you can send to your relatives, prompting them to talk to their primary care physician about getting an echocardiogram. So one of the most common causes of aneurysm or dissection, or at least maybe most known in the lay population, is a disorder called Marfan syndrome. So Marfan syndrome is a classic connective tissue disorder that is characterized by aortic aneurysm and dissection. About 60% of patients have lens dislocation, where the lens kind of subluxes up or out of the typical positioning, also increasing risk for retinal detachment. There are some very specific skeletal features associated with it. And Marfan syndrome is caused by variants in the FBN1 gene, or fibrillin-1. It is an autosomal dominant condition. So in 2010, a group of renowned specialists got together and kind of redid the criteria for Marfan syndrome. And this takes into account family history, genetic testing information, your eye features, your skeletal features, and your cardiovascular features. So in terms of kind of the skeletal criteria for Marfan syndrome, some of the things that we think about are kind of going around the circle, starting with the hands. We think of arachnodactyly, or long fingers, which we can assess this by doing these specialized wrist and thumb signs. We see a pectus deformity, where the chest wall kind of does this asymmetric dip in and out. We can think of flat feet, or where the ankles are rotated. There's some specific radiographic features called dural-ectasia, or widening of the sac around the spine, and also some pelvis bone abnormalities. We think of disproportionately longer arms compared to the height, as well as short torso compared to legs. And then there can be some other skin manifestations like the striae, and these characteristic facial features like down slanting palpebral fissures or eye spaces, flat cheekbones, maybe a little bit of a recessed or small chin. So the implications of a Marfan syndrome diagnosis really help us guide other management as well. So we think about orthopedic follow-up as that people might need bracing or intervention, surgical intervention for scoliosis, sometimes inserts for flat feet. Often, the chest wall anomaly, even though it can look pretty severe, usually doesn't impact heart or lung function, but can be a cosmetic concern for people. We do know that individuals with Marfan syndrome need routine eye care, looking for lens dislocation, addressing risk of retinal detachment, but as people get older, assessing for risk for glaucoma. As well, not only for Marfan syndrome, but for all of these disorders, or for aneurysm and dissection risk in general, there are also specific exercise restrictions. So avoiding isometric exercises, these are your sit-ups, push-ups, pull-ups, weightlifting, avoiding exercise to exhaustion. So running a 5K with your family for fun is great. Running a 5K to get your personal record where you can't breathe at the end, not so great. And then avoiding contact or competitive sports, really where it's someone's goal to check into you, or you could get a ball to the head. So the diagnosis of Marfan syndrome really guides our medical and surgical cardiovascular follow-up. Usually we're going to be getting echocardiograms at least on a yearly basis. If there's rapid growth, or if you're reaching surgical thresholds, maybe more frequently. Usually in someone's young adult years, we begin doing CTAs and MRAs of the chest, abdomen, and pelvis to look at their descending aorta and other portions of the aorta. There's variable research on use of blood pressure medications and which is the best. We do suggest some type of blood pressure medication, either a beta blocker or angiotensin receptor blocker. And surgical threshold for surgery is typically around 5 centimeters, although many hospitals, because of the safety and efficacy of the surgery, are decreasing that threshold to about 4.5 centimeters. In Marfan syndrome, or emergency risks do include aortic dissection, retinal detachment, which would be like sudden loss of vision or a big black floater that doesn't go away, and then risk of a pneumothorax or collapsed lung. And again, this disorder has a 50% recurrence risk. So in about 2006, we recognized that there was a quote unquote cousin to Marfan syndrome that was presenting pretty aggressively, and they had some unique craniofacial features. And this included hypertelorism, or wide spaced eyes. Individuals had kind of mild craniosynostosis, so some overlapping sutures of the skull bone. They were more often to have cleft palate or bifid uvula. We saw similar presentations in the skeletal system, including pectus and scoliosis, but in this population, we were seeing a lot more club foot or some cervical spine malformations, as well as more evidence of contractures in the fingers and toes. On imaging, these individuals really showed more tortuosity of the arteries and also the aorta, and they were more likely to have smaller dissections in other blood vessels. We have also begun to appreciate and study an increased prevalence of allergic disease and GI disease, which is kind of inflammatory disease known as eosinophilic esophagitis. So kind of allergic disease presenting in your esophagus as difficulty swallowing or food allergies. In Loeys-Dietz, we see a lot more translucency of the skin and atrophic scarring. It's also a dominant disorder. So this disorder is near and dear to my heart because I started the foundation. And so you can definitely see that some of these families have distinct craniofacial features, but many of these individuals too do not. And I wouldn't be a geneticist if I didn't show you my obligatory picture of bifid uvulas that come to me in the email. So you can see all different subsets of raphes and bifid uvulas and cleft palates and that wanted to be. So currently there are 5 subtypes of Loeys-Dietz syndrome. They're all genes involved in this pathway called TGF-beta pathway. You know, there's possibly a 6th gene, and there are certainly more genes in discovery for Loeys-Dietz syndrome. There can be quite variable expressivity. So we talked about kind of those kiddos presenting on the severe end of the spectrum, including the much more severe craniofacial and skeletal features. But on the milder end, we can see, again, less prominent craniofacial features. They do tend to present with the cutaneous features of wide scars, translucent skin, many hernias, milder scoliosis and pectus deformities, and perhaps not as young onset of aortic or arterial dissections. And some cool pictures of vascular findings that we see outside of the aortic root. So again, we see these windy blood vessels, these tortuous arteries. Sometimes they can even be pigtail turns, particularly in the neck vessels or the vessels going off into the abdominal organs. You know, this next picture is a little girl that we follow who had aortic root replacement. She had very rapid progression of ascending and arch enlargement after that. We can see aneurysms in other blood vessels. So you can see aneurysms in these popliteal arteries behind the knees and vessels going off to the kidneys and the SMA. And then this is a nice picture of a dissection propagating all the way down the aorta. So big difference is when a cardiothoracic surgery is performed in Loeys-Dietz syndrome. Usually surgical thresholds are lower than that 5 centimeter threshold. It is dependent upon the gene. We also take into account the specific variant in the gene and also what we can learn from your family history. So if there have been multiple people in the family who've shown dissections at aortic sizes in the low 4 centimeters versus a family whose people in the family who have made it to 5 without dissection, we would take this into consideration when making surgical recommendations for you. And in this disorder, although there can be mitral valve issues, I would say it's much rarer than in Marfan syndrome. So again, implications of this diagnosis, we're still going to do echoes. You know, CTAs and MRAs, we're going to actually do head to pelvis, usually every 2 years, more frequently if anything is found. There is increased risk for allergic or GI disease, so oftentimes we need to get those colleagues involved. Some types of Loeys-Dietz syndrome can have cervical spine abnormalities, so we at least want to do baseline flexion extension x-rays of the neck and consider this before surgical intervention. We feel pretty strongly that we should use angiotensin receptor blockers as the blood pressure management. We're also excited to partner with the NIH because they are doing a natural history trial. It's based under the Allergy and Immunology Department, but they offer studies that are free in endocrine and bone studies and dental. They offer a lot of pain management and other multi-system evaluations. Emergency risks in this disorder include not only the aortic dissection, but arterial dissection risk, the retinal detachment, the pneumothorax. There has been rarely described hollow organ rupture, but if someone is presenting with abdominal pain, it's something we think about. And again, a 50% recurrence risk. So vascular Ehlers-Danlos syndrome, or VEDS, presents with thin or translucent skin. These individuals can have very wide or atrophic or cigarette paper-like scars with significant bruising. Very common in this disorder from a vascular standpoint is arterial fragility. So many of these people have asymptomatic dissections in the neck vessels or in the iliacs or the abdominal vessels. There can also be hollow organ rupture, which is probably the most common in this compared to anything else, especially bowel rupture. And so presenting with significant abdominal pain should be taken very seriously in this population. Collapsed lungs are also pretty common in this population. About 30% of patients present with this. It's important to know that with this disorder, there can be spontaneous arterial or aortic dissections. So you don't usually see big aneurysms growing. You just see spontaneous dissection of blood vessels. And often you're going to see a brain aneurysm rupture, and then an aortic dissection, and then an iliac dissection. So you're likely not going to see this 3-generation pedigree of aortic aneurysm dissection. So this again is an autosomal dominant disease, and it's caused by gene changes in type 3 collagen called 3A1. And again, implications for a VEDS diagnosis, again, we have all the imaging complications. We usually are going to treat individuals with vitamin C that helps with cross-linking of collagen. We really want to help people avoid any constipation because of that bowel rupture risk, and aggressively avoid hypertension. And again, there is a 50% risk, and emergency situations in this really include education of our emergency rooms for hollow organ rupture, especially in the bowel. So finally, we have a category of disease called familial thoracic aortic aneurysm syndrome and dissection. These are disorders that are usually caused by gene changes in our smooth muscle vasculature. So the way that our smooth muscle in our aorta and our arteries contract. Usually people tend to be a little bit less syndromic, so not a lot of skeletal or cutaneous features, but they can have livedo reticularis, which is kind of like a honeycomb pattern in the skin. They might have some family histories of occlusive disease like strokes or coronary artery disease. On echo, some individuals can have other cardiac defects. This is also inherited as an autosomal dominant disorder, but there can be incomplete penetrance. So someone might have the gene change, but might not show aortic aneurysm. And so again, there's a variety of gene changes associated with this and kind of rules for each one about when it presents, what is really the risk. Many of these individuals, though, might be at increased risk of dissection a little bit later in life. So again, it's really important to consider these genes when you're thinking about genetic testing. The big difference for implications includes yearly echocardiogram, an increased risk of cerebrovascular disease, so stroke or coronary artery disease, and again, it's a dominant condition. So finally, we have bicuspid aortic valve and aneurysm. We know that individuals in families with this condition can present variably. So in some individuals, you can see bicuspid aortic valve. In some individuals, you see the BAV and aneurysm. Some individuals, you see aneurysm. And in some individuals, you can see severe left-sided heart defects like hypoplastic left heart or coarctation. This is usually a milder presentation in terms of aggressiveness. This is a disorder, though, because of the severe left-sided heart defect, where we would say if you have this, fetal echoes should be performed to look for these severe heart defects in a pregnancy. We maybe know about, less than 3% of the genetic cause of this. These genes are on the aneurysm panel. But this disorder is a little bit harder to screen for in families because aneurysms can present over time. They can be milder. They can present without the BAV. So in this disorder, it's really important to think about family echo screening and to be repeating echoes every few years. So in terms of how do you find a genetics professional to help you through testing, consider nsgc.org to look for genetic counselors, especially those who might specialize in cardio conditions. acmg.net has a way to look for geneticists that can offer testing. And then marfan.org, you can access their institutional directory to find centers of excellence near you. Thank you.